Technology. All right, so welcome everybody. I can't believe so many people are on this webinar and choosing to hang out with me on a random Thursday afternoon. This pandemic has been going on for 2.5 years, and yet you are still going on Zoom. God bless America, or Canada even, there's Canadians on here. I am so honored and grateful that you are here. And really, my goal for this webinar is to introduce myself and learn from my friends Reshma and Anina, who have teach me all the time. And I'm so blessed to have as a part of my practice in my life. And really our chance to just talk about how important pelvic health is and how complicated it can be. I told a patient today, can you believe with all of the training that I have, all of the years, all of the hundreds of thousands of dollars I've spent on my training, there is still so much I don't know about the pelvis. And I'll be the first to admit, I wish I knew more about hips. I wish I knew more about nutrition. I wish I knew more about the lower back. And so we are all constantly learning, and you have to learn in community, and you have to learn with your friends. And you also have to have the time for patients to teach you, right? I am always learning from my patients about their stories, about their lived experiences. And when a patient says, no, Dr. Rubin, this is where I feel it, and this is how I feel, and this is where it hurts, and this is what I think is going on, I love spending time digging into that and diving in deeply there. So thank you for all being here. We're going to keep an eye on the chat box. So if you do have questions, we certainly want to answer them, and we'll save time for questions. What I'd like to do in just a moment is have my friends Anina and Reshma introduce themselves, and then each one is going to talk a little bit about what their experience has been working as a team. We actually had a little pilot project. So for anyone who doesn't know, I just started my own private practice, which is so exciting. We're officially open. It's in Rockville, Maryland. We had just started seeing brand new patients this week. We've been seeing some old patients recently, and it's going great. It is a scary adventure to open up your own private practice, and I'm learning so much. But before I opened my doors, I was blessed to join Reshma and Anina in what we called Comprehensive Pelvic Pain Clinic. And we met with patients for about an hour, and we really dove deeply into their problems, and it was miraculous. Gosh, I learned so much from Anina and so much from Reshma, and so we were hungry to do more and to see more, and really believe we can make a big difference in people's lives by really understanding them more holistically. And we said, wait a minute, I think I actually left the clinics frustrated. And I said, it's actually not enough. We need more time. I feel like we're not even scratching the surface with only an hour. And I'm pretty stubborn, and I like to get my way. And I said, this is enough is enough. We're doing 2-hour visits. We have to spend more time hearing people's stories, and then really examining thoroughly and coming up with plans, and then the education piece. So you hear people's stories, you do the exam, and then you have to, help educate. And I need to learn, from Anina and Reshma of what's going on. So we've expanded our clinic to actually be 2 hours long, which is so wonderful. And I want today you to hear some stories about the things that we have found and the things that we have learned. And of course, we do have some dates open for our March 18th and April 22nd. There's only about 4 spots left. So if it's something that you think it's something that you want to be evaluated for and want to come to Washington, D.C. area, we would love to have you and work with you. So I didn't introduce myself. Maybe I should have. I am Rachel Rubin. I'm a urologist with fellowship training in sexual medicine, which means I take care of all genders for all sorts of issues, whether it's pelvic pain, hormone issues, erectile dysfunction, low libido, orgasm problems. And I can't do my job alone. I require a team in every patient that I see, whether it's from pelvic floor physical therapy, mental health professionals, amazing nutritionists, pain management doctors, whoever I have to work with, I will find a way to work with them. And so with that, yes, this recording will be sent out. We'll find a way to post it somewhere and shout about it on social media. If y'all don't follow us on social media, we'll put our handles and make sure you have all of our information. So Reshma, Anina, who wants to start? Who's going to be brave and be the first one?
I can go first. I'm Reshma Rathod. I'm a physical therapist, and I've been a physical therapist for well over, oh my goodness, 25 years. I'm dating myself. And I'm just very, very excited to work with Rachel, Dr. Rubin. We had this great idea of starting this interdisciplinary pelvic floor clinic to help those that are suffering from pelvic floor dysfunction and any issues with pelvic floor dysfunction. When we started this clinic, I would say about 7 or 8 years ago, it's very, very successful. And then we were able to revitalize it again with Dr. Rubin, and her interest and having Dr. Burns as well. Dr. Burns is a nutritionist, so we felt with the medical aspect and the physical therapy aspect and the nutritional aspect, we could help those that are suffering from chronic pain. And why physical therapy with pelvic floor dysfunction? And often what happens is when you're in pain, your muscles can tense up, they can weaken, they can become irritated, even your joints and your ligaments. So what we do is we take a look at you holistically and comprehensively. So we're not just looking at your pelvic floor. We're looking at your back, your hips, sometimes your feet, sometimes your TMJ. Did you know that there's a strong correlation between your mouth, your TMJ to your pelvic floor, or sometimes headaches and migraines, and that has a strong correlation. So we'll take a look at you holistically, and we've had such great stories and success. We've had some folks that have come in, with chronic pelvic pain, unable to have penetration, intercourse, or even sit for a long time, and only after a thorough exam really to realize that either they had hypermobility, they've had some chronic headaches that through some diet and nutritional suggestions and through exercise suggestions, they've been able to make a change and a difference. And it's been great. It's been, I feel like we've been able to help out many, many folks. So not only, we're able to help those out that have had weakness, if you've had prolapse, if you've had urinary incontinence, we're able to help out, really take a look at holistically. We've had some issues where there were some women that have had bladder pain, and their bladder pain was most from their C-section that they had maybe 30 years ago. You've had these scar adhesions, and sometimes these scar adhesions can affect bladder function or cause constipation sometimes, and sometimes addressing some of those adhesions can help improve your function, and so that you're happier and healthier. And I want to introduce myself to introduce you to Anina, who's able to share a little bit of how nutrition can help pelvic pain.
Thank you, Reshma. I really appreciate that. Hi, everyone. I'm Anina. So I'm a registered dietitian and licensed nutritionist. I also have a PhD. I'm certified in functional medicine. And for those of you who are familiar with functional medicine really looks at the root cause of diseases. So instead of saying I have a headache and a doctor might say, well, just take an aspirin. Functional medicine said, why are you having chronic headaches? Like, what is inflamed in your body, and why is that coming out and expressing itself in terms of a headache? I've been in clinical practice for 10 years. I've focused on women's health and hormones. I've recently focused more on fertility, although I still see a range of patients through the pelvic health clinic and others. And I really love nutrition because it provides you a whole different perspective in your body, a different form of healing on top of the physical therapy, which is the physical manipulation and really figuring out, mechanically what's going on. And Dr. Rubin really, looking at the hormones and kind of dissecting into the diagnosis of what's happening. Nutrition will give you kind of that comprehensive treatment. And what I have found, I've had a number of patients who've experienced bladder issues, vestibulodynia, painful intercourse, and just in nutrition alone, I've been able to see in my own practice a reduction in their symptoms. And that's the really neat thing. If we can reduce the inflammation and we can target it with specific nutrients, so there are a number of nutrients that particularly inflame the pelvic area, and there are nutrients that actually support the pelvic area, and it's personalized by the individual patient. So not everybody, it's not like a one size fits all, but I've been able to manipulate with different nutrients, changes in diet, changes in supplementation, changes in like the way that you're absorbing your food and looking at gut health. So that's a big thing too, is a lot of times people who experience chronic pain and pelvic dysfunction often have gut dysfunction. And so there's a nutrient assimilation issue and absorption issue too, because your nutrients will help your body heal if you're getting the right nutrients for your body and for your condition, but sometimes you can't do that if there's gut dysfunction. And a lot of my patients have not realized that they do have that gut dysfunction. So I do lab testing, good clinical evaluation, and also changes to see whether or not we can get a reduction in the symptoms, especially related to pain. And I've done the Pelvic Clinic with Reshma for over 5 years, and it's been an extraordinary opportunity, I think, because a lot of times you'll go to a nutritionist separately who won't talk to your physician, who won't talk to your physical therapist. And often there might be conflicting things coming from each one. And the neat thing about the Pelvic Clinic is that you have everybody in the same room who we're understanding the diagnosis that's happening, and we're talking about the diagnosis, and we're collaborating and giving you a comprehensive plan. And nutrition can be a really key part of that plan. And I think so often people think, oh, I know how to eat, I eat pretty well. But I can tell you, and every client that's walked through my door and I've worked with, there's always room for improvement. It's just hard for us to see. And food being, so commonly discussed and talked about, and it's in every magazine, you should eat this, don't eat this. And of course that changes by the month and by the year. A lot of people feel like they have a lot of knowledge, and they do, but it might not be the right knowledge for your specific condition and your body. So that's the really neat thing that I've seen nutrition do. I even do some genetic testing, and a range of like functional lab testing to really try to get at the core of what individuals need. And it's been exciting to work with the Pelvic Health Clinic. And I look forward to your questions as we discuss more. I'll hand it over to you, Dr. Rubin.
Yeah, I always say that. I say no one's so good at sex, they can't get better, right? Everyone can get better at sex. And so everyone can get better at nutrition. I think we can all agree. And certainly musculoskeletal health, when you go to physical therapy, I say, well, they might tell you that you're breathing wrong, you're peeing wrong, you're pooping wrong, and that they have to, redo all of your mechanics. And it's amazing that you can function in the world. And so we obviously come in from a place of love, and also how can we optimize quality of life? And how does it all work together? And I will tell you, when I've been in this clinic, I am so jealous because I've never sat in a room with different providers just listening to my story and hearing my history and what's going on, and put, such smart brains together to say, oh, well, what about this? And have you tried this? And have we done this before? And take a very, standardized approach to really understanding the story. And then from a physical exam perspective, I am so lucky because I get to watch Reshma, watch her, look at people's gaits and how they sit and their alignment and their spines and their hips and their feet, for goodness sakes. No one taught me in urology school how to look at feet. And so I learned so much. And then I see where her brain is going, and she's talking to me while it's happening. And then I ask questions, and the patient can ask questions, and we're all learning in this really cool environment to say, well, what about this? And have you thought about this? And really, when does that happen? I mean, medicine should be this way. This is the way medicine should be practiced. It's just that everyone's too busy. And schedules are too complex, and it's too hard to get everyone together. And insurance companies don't care about, time with people, as we know. And so I'm really blessed to say, listen, not everybody needs this in-depth evaluation, but there are people who have had pain for 30 years. There are patients who have hypermobility syndromes where everything hurts and everything doesn't feel right. And we saw a young man in our pelvic clinic who we were able to sit down and say, hey, we think that you have a hypermobility syndrome that is probably affecting your bladder health and your musculoskeletal system, and nutrition can play a role in all of this. And it was wild. I mean, just the light bulbs that went off and building that proper program and getting the patient to the right place is really, really beneficial. And I think it's been really great. So I want to open it up to questions from people, because rarely do you get to be in a forum and learn from others. I find that learning from others is really helpful. And I'll be the first to say that I do not know everything, which is why I always have friends around me, and no one's not a text away. And so you are all here, which is incredible that you found this on social media, or you found this gosh, tell us how you found it. I don't know. Maybe you're signed up for our mailing list or something like that. And so you have something that interests you about showing up to this. So whether you're a provider or a former patient or a future patient. I see all of you on this call. And so go to the chat box. Don't be shy. I won't make you go off mute. And if you don't come up with anything, I will ask Reshma and Anina a bunch of questions, because I saw, 5 people today that I have questions about their musculoskeletal system and their nutrition. So we're going to ask the first question we're going to give to Dr. Burns here. What foods would increase pelvic floor inflammation, such as dysperunia, which dysperunia is painful intercourse? So I love that question.
Yeah, so there's a couple of areas. So first of all, there's some general inflammatory foods. So dairy and gluten, as you often hear about. But more specifically, oxalates can also increase pelvic floor inflammation and dyspareunia. So oxalates are compounds that are found particularly in tart foods. So that's kale, that's dark chocolate. Unfortunately, it's red wine. It's your darker beers like your Guinness, so forth. So your tart products, even tart apples like Pink Lady apples are high in oxalates. So I find when people can reduce oxalates, it can actually decrease painful intercourse sometimes. It does take several weeks of strict adherence. So I think this is the big thing with nutrition I want to emphasize. A lot of times people are like, yeah, I tried that a little bit, sort of, kind of, not really. You're not going to get the result that you need nutritionally when you have specific physical symptoms if you don't kind of go all in for a short period. It doesn't mean you have to do it forever. It's a test to see if it'll help you. But you do need to do it 2 to 3 weeks, about 21 days, to see whether or not it's going to make a difference. And it should be like a 0%. So no red wine, no rhubarb, no kale, no raspberries and dark chocolate during that period. There are other foods too. You can actually look up oxalates. There's a lot of lists out there. And while that may seem restrictive, having the benefit of reduction in pain can be remarkable for removing some foods. Back to you, Dr.
Go ahead, Reshma.
Well, I see a question about would pelvic floor physical therapy help with erectile dysfunction? And so I wanted to jump in and talk about that a little bit too. It really depends on what's a contributing factor to the erectile dysfunction. If it's mostly musculoskeletal, then yes, addressing some of the pelvic floor muscle, like Kegels type exercises, can help improve the tone in that pelvic floor, improve the blood flow in that in the area to help improve erectile dysfunction. We really need to figure out what that cause is. So if there is anything else, like if there is if there's some sort of scarring that's limiting it, if there's some sort of neurological issue that's limiting it, that's something that we do need to take a look into. But if it's strictly a musculoskeletal situation, then absolutely that's been helpful.
So I see a couple questions. I'll jump in. And again, on the erection issue, it's so important. We don't think of the musculoskeletal system as helping erectile function. And I think it's a very underlooked at area. The muscles that surround the penis are sort of God's internal constriction band, or cock ring, if you will. And if we don't really think of the muscles behind the scrotum in that perineum are muscles that you can train, but you absolutely can exercise them. And they can be very weak over time. Say you're on that Peloton bike every day, you maybe have damaged that muscle sometimes. And so physical therapists can help evaluate that muscle. Is it too tight? Is it not contracting the right way? Can you exercise it? I had a patient just today who said, well, I can't even strengthen the muscle because it's in too much of a spasm. And so I have to work on relaxing the muscle, even though everyone says, do Kegels, do Kegels. And so similarly, I want to just let everyone know, because I have a lot of questions coming in about the vestibule, and I'm going to throw up some slides in just one second. When we're looking at these issues, we really take an approach that I like to call sort of a region-based approach for any problem that someone sees me for or sees us for, whether it's pelvic pain, low libido, erectile dysfunction, orgasm problems, lichen sclerosis. I take an approach of what is going on locally at the tissue level, right? What's going on in the nerves that innervate these tissues, and what's going on in the brain. And we can look very carefully, at each level to say, where can we make the biggest impact? And so when we do vestibulodynia, I'm going to share my screen with you just for a second, because a lot of people on this call may not know what vestibulodynia is. I will share my slide with you. So the vestibule is the opening tissue of the vulva. And so if you see my slides here, you see my slide, Reshma, does it come up? Well,
Thank
okay.
you.
So if you see on the inside of the labia minora is a tissue called the vestibule. And this is the same as a male urethra. It's bladder tissue, actually. So everywhere that's not red on this picture is skin. Everywhere that's red on this picture is bladder tissue. And the vagina is a completely separate type of tissue altogether. Now, probably one of the most common reasons for painful sex is a pain in this vestibule tissue. And the three most common causes are hormone problems, pelvic floor problems, and too many nerve endings, or what we call neuroproliferative. And so it's really important that you see someone who knows a lot about this, because then they can differentiate between these three.
Rachel.
Hey guys, I think Rachel just froze and she's coming back on. She's just logging back on. Right in the middle of a very good presentation. I can't hear you, Reshma. You're muted.
I got thrown out of my own webinar, huh?
You did, but you're back.
God bless America. Where did you lose me, Anina and Reshma? Oh,
you're just talking about the three causes of pain, and you started with hormones regarding the second cause.
Oh, I was just talking to myself, you guys. So my new office is amazing and I love it. But every day at 4:30, apparently the internet just goes out. So if anyone knows somebody at Comcast who can call me and figure out why that is, it's very exciting. So let me just share my slide with you one more time. And I'm so sorry about that. Do you see my slide? Give me a thumbs up, Reshma. Cool. So again, hormones can cause vestibule pain, pelvic floor problems or muscles can cause pain, too many nerve endings can cause pain called neuroproliferative. And some people are just born with that and we have to really diagnose it. The hormone issue is so fascinating, right? The vulva is very hormone sensitive, extremely hormone sensitive. And you will hear me say this over and over again. When you play with hormones, there are consequences, sometimes really good ones and sometimes really bad ones and everything in between, but there are always consequences. And so when you take something like a birth control pill, it can increase a protein in your liver, which can decrease your testosterone. It's called sex hormone binding globulin, or SHBG. Everyone commit that to memory, SHBG. And it binds, it's like Pac-Man, it binds to the testosterone in your body, which cause the vestibule to be red and painful, as you can see here. And so what we often recommend when we think there's a hormone cause, we tell the patient to stop their hormonal birth control, consider an IUD, which tends to be, or an Explanon, seems to be less caustic to this tissue. And we usually add back some hormone, and we do that with a gel of a little estrogen and a little testosterone. And it really does help the tissue significantly over time. It takes a long time to heal this tissue. And Reshma, tell everybody how important pelvic floor, treating the pelvic floor is to this tissue.
Okay. It's absolutely important because when that tissue is irritated, what often happens is we tighten up, right? We're guarding ourselves. And as we're guarding ourselves, these muscles tend to develop these trigger points. These trigger points can also refer pain, and the pain, it could be referred to the vestibule. It could be referred to anywhere else in the general area. But these trigger points, because they refer to these little muscle, they're knots. And if we can help improve the flexibility of those muscles and decrease those knots, that can also help decrease the irritation in that general area.
And these muscles are the same muscles in all genders. Okay. So that's what's really important. So you could have pain. Gosh, my male patients may have, they're getting up at night to pee. They have urgency. They have ejaculatory pain or constipation. All sorts of symptoms that you don't think of as musculoskeletal actually end up being a musculoskeletal. So
it's the same anatomy, just different plumbing.
and so Reshma, the great question here about in terms of patients who have hypermobility and hypertonic pelvic floor muscles, can you talk a little bit about what hypermobility is and what you see? Because you have such wonderful experience treating patients with hypermobility.
So often what happens with hypermobility, the joints are moving too much, right? And so beyond what we would deem normal. And sometimes with those those hypermobile situations, either you don't have the stability to for your muscles to function appropriately, or your ligaments could develop this this repetitive sprain pattern. So like as if you're chronically spraining your ankle over and over and over again. Sometimes that's what happens with hypermobility, but not necessarily your ankle. It could happen to any tissue in your body. It could affect some of your joints in your back. It could affect the heart. It could affect the gut. It could affect the eyes. So this hypermobility is a connective tissue situation, and by not having the stability of your joints or your muscles, that can cause this repetitive strain pattern that we often see.
And Dr. Burns, with your patients with hypermobility and nutrition, what are your thoughts on how the differences in nutrition can help? And can you talk about histamine a little bit, because that's kind of a hot topic?
Sure, absolutely. So I actually have seen a lot of patients with hypermobility. And the thing about hypermobility is your cellular function. So not only are your joints and ligaments looser, as Reshma talked about, but your ability to get sodium into cells and potassium in with your electrolyte balance is not the same as someone without ED. So you have to compensate for that with diet. Diet is the best way to do that. And so really making sure that sodium potassium balance is optimized. And for a lot of my patients, that means more sodium actually in their diet, that need more salt in order to maintain that electrolyte balance that's needed, that then can support their joints and support their other tissues at the cellular level. And in terms of food, the hypermobility patients have to watch out for inflammation, right? They're prone to inflammation. So an anti-inflammatory diet is what's really prescribed for people with EDS on top of the electrolyte balance and the sodium content. And Dr. Rubin, you asked about histamines, and histamines are a hot topic. And I saw someone in the chat said like low oxalates versus histamines. Those are two different things, although there are similar foods in both groups. So histamines are, you think of like when you have seasonal allergies and you sneeze, right? And you sneeze a lot. So that's a lot of histamine production associated with runny nose, ruddy red cheeks, eczema in some cases, and rosacea. And you take an antihistamine to reduce those symptoms. Well, the neat thing about food is you can do that with food. There are a lot of foods that are histamine promoting, and there are foods that are antihistamine. So foods that are histamine promoting are alcohol is a classic one, fermented foods. So that's even kombucha and kimchi and so forth. Your fermented foods are also, your beer and your other alcohols, but aged foods too. So if you like aged cheeses, and for some of my clients who have chronic migraines in terms of histamine, even just not eating day-old leftovers has made a difference. They really need to eat their foods fresh because histamine is produced in the aging process. And that could be as simple as leaving your turkey in the fridge for a couple of days, and there's a lot more histamine in it. So an antihistamine diet, and there are a lot of fruits and veggies that kind of fall into list of antihistamine, can be helpful generally. Like even if you have seasonal allergies, it can be helpful, but certainly with EDS and situations where you have chronic pain and inflammation.
So that brings me another inflammatory condition that's being asked about, which I'm so glad is being talked about, is lichen sclerosis. Do we think it's more common than we talk about? There's no question that if no one looks at the vulva, how are they going to diagnose lichen sclerosis? Primary care doctors are taught not to look. Gynecologists often put their speculum in and bypass the vulva completely. So Reshma, as a physical therapist who looks at vulvas, frequently, were you surprised at how much lichen sclerosis or tissue changes that you've had to train your own eyeballs on to say, hey, you know what, something's going on here that's not just musculoskeletal. Maybe you should see a Dr. Rubin or somebody.
Oh, absolutely. Often what happens is that we'll see the gynecologist or a urologist might send us patients that have pelvic pain, and they're not quite sure why their pain is. And often often it's related to a tight pelvic floor or an inflamed pelvic floor, a weak pelvic floor. But often we could take a look at the vulva and determine if it's lichen sclerosis, and it's this the anatomy just looks a little bit different. The anatomy, there's just this it's thin, you tend to lose a little bit of the labia minora, and it tends to fuse in with within the vulva. So and that's where we're seeing some of the pain. Sometimes it's the scarring or decreased mobility. So sometimes just relaxing the pelvic floor or doing some scar massage to the area could help in addition, but that's not the only thing that would help the lichens. We definitely need medical management, and from a qualified physician, a physician that really knows and understands lichens. And unfortunately, there are not too many of them that really.
We're trying to teach, and many of them are on this
more.
call, and we're so grateful for all the providers here, because I think there is some mistakes that happen with lichen management. And I think the big one is they don't do enough hormone management and genitourinary syndrome of menopause management with it, because lichen sclerosis happens in hypoestrogenic states, right? Prepubertal kids get it, and postmenopausal women tend to get it, and sometimes in between, but really the majority is in when you don't have enough hormones of the tissue. And so, yes, potent steroids are very important, and they need to be maintenance. You need to get to a point where you're sort of regularly doing it, but also maintenance with hormone therapy is exceptionally important, in my opinion. And then what we do about, right, with the loss of tissue or the clitoral adhesions that happen, right? You can lose that clitoral head that typically you should be able to see. And we have new data and research coming out. Some of my amazing research students are on this call who have discovered that by stretching open that hood or getting to that the head of the clitoris and getting that out, it can improve orgasm, arousal, desire, satisfaction, and it's life-changing for some of these patients who do get a loss of architecture and a loss of anatomy. So more data that is coming out about that, and we're so excited. We'll definitely share it when it all comes out. But again, Dr. Burns, because it is an inflammatory condition, I imagine really looking at diet and nutrition is not a cure, is not the only thing that you need to do, but certainly might be helpful in managing these patients.
Absolutely. What you need to remember about diet and nutrition is it's like breathing, right? Day in and day out, you're eating, you're drinking. So you are influencing those tissues all the time. And that's the amazing thing about diet, is it has the ability to really help the body repair and also prevent as well. But you have to do it. So an anti-inflammatory diet. So I talked about a low oxalate diet. I talked about antihistamine, but there's also anti-inflammatory, which is a third category. And again, there's overlap in those foods, but avoiding like major inflammatory foods, sugar being a big one, processed foods, meats, dairy. It doesn't mean you have to completely avoid everything, but those are like your big inflammatory foods: corn, soy, eggs. White flour is a big one. So when you inflame the body with blood glucose, so your blood glucose is going up and down, you're in a more inflamed state in your entire body. And that's going to manifest itself in the area that you're actually most sensitive, right? So some people it'll be gut, some people will actually be the skin, if people have skin issues, eczema, rosacea, or acne. And for some people that'll actually be in the vaginal tissue, in the bladder, and so forth. So an anti-inflammatory would be foods that reduce inflammation. So everybody kind of knows about salmon and fish oil, but turmeric, fruits and veggies, anti-inflammatory foods, good quality fats are really important here, and keeping that blood glucose nice and steady, which means not processed foods, right? You can have grains, but they need to be complex whole grains that don't move your blood sugar up and down.
I want to give a big shout out to Margaret Ellen, who's here. Everyone say hi to Margaret Ellen. Yay! Margaret Ellen is my new assistant, who is a doctor. She just graduated medical school, is waiting for her emergency medicine residency to start. So in just a few months, there will be an emergency medicine physician who knows everything about sexual medicine, which is just going to be the best thing ever. And so the more people we can train in the more different specialties to know that everyone is responsible. No one type of doctor owns sexual health or pelvic health for that matter. And actually, it's a really big challenge because, you expect your neurologist to know everything. You expect your gynecologist to know everything. You better expect your urologist to know everything, or your orthopod. And the answer is the pelvic is a little bit no man's land. Everyone sort of has said, oh, not it. I don't want to do this. And it's a big problem because we don't talk to each other, and we all have ownership of the pelvis, right? Hips and low back and genitals and urination and bowels. And yet we have so little understanding and ability to work together. And so I don't want to keep you all on for too much longer. Hopefully this has been helpful and you've learned a few things. I know we did not answer every single question out there, which is why we really want you all to come on social media, ask the questions as a community, because you all have lived experiences that are really important. And actually you have things to teach us. And the only reason we figure out some of these conditions like persistent genital arousal disorder or certain pelvic pain conditions is when patient groups get together and demand advocacy and demand change and demand research. So whatever we can do to push that forward, it's a big, big goal of all of ours. And so we're going to put into the chat, everyone put in their social media handles. Hopefully you guys know by now, I'm Dr. Rachel Rubin. Sign up for our mailing list at rachelrubinmd.com, because as we do more events and things like that, we would love to let you know about them. I'm going to share my screen and show you again that we do have a few slots available. You can call Margaret Ellen and she will tell you we have a few slots available for our pelvic clinics in March and April. We don't do them all the time because we are all very busy practitioners seeing individual patients, but there are some patients who I want to spend 2 hours with. I want to spend 2 hours really figuring out what's going on. So if you think you are a patient who needs more time and really to get different brains together, we want to see you. And we really want, if you want to travel in, we would love, we've got hotels really close by. We would love to work with you and find a way to really get the best plan of care. Because also if you live from far away, we know physical therapists in your area. We know doctors in your region sometimes. And so we can really help get you a good plan of action. So, or you can move here. We wouldn't mind that either. It's a very lovely place, the Washington, D.C. area. So any last thoughts from Reshma? Any last thoughts?
I think it's, you don't have to live like this. And if you're having some issues or dysfunctions, please seek help. And if your physician, if your medical care provider is stumped, just know that there's resources out and available to help you out, to offer some solutions, any solution that we're able to offer.
And thank you so much for being here, Dr. Burns.
I would just say, I mean, as Dr. Rubin said, like, I wish I could have a clinic where I could have my providers all in one space, because, I'm also a patient too on the side. And it's so frustrating when you hear one thing from one and you wait 3-4 months to see someone else and they say something differently. And I actually love the pelvic clinic because I just like, wow, what an amazing opportunity to have those providers in the same space. I learn a lot, but also I just think it's like tenfold for the patients, like the benefit that you get. So if you're just kind of on the fence about it, I mean, I would say, like, if I could do it, I would do it in a heartbeat, because I do think it gives you that benefit. So think about it from that perspective, the amount of time it might take to see 3 different people and try to put out the pieces together in the puzzle, versus 3 people who work together and will be in the same space. And that's all I have to add.
There's one thing actually I wanted to add. Oh, there's one more thing I wanted to add to piggyback on what Dr. Burns was saying, is that with Dr. Rubin's network and Dr. Burns's network and the network that we have at Restore Motion, if we feel like you need to see a specialist, with let's say an orthopedic surgeon, and you're waiting 3 or 4 weeks to see an orthopedic surgeon, through our network, we're able to go ahead and facilitate that appointment sooner than you would have, if you had called on your own. So, using our network, we're able to get you, we try to get you appointments sooner than later, so that we could help.
We've got friends. What we mean by network is we just have friends all over, and they answer our text messages and our phone calls and are begging, and having myself or Reshma or Anina as your advocates is always it's always a good place to be. And so really, I want you all to follow us on social media, but most importantly, share your stories, talk to your friends, talk about these issues, and talk to your friends about what you've heard. Share this information, because other people can really benefit. We're going to have a big menopause a seminar coming up. I'll send out some information about that. So if you find yourself in your early 50s and want a group visit where we can really teach you for several hours all about menopause, or patients who are having that, keep an eye out, because I'm really excited to pilot some different group visits, individual visits, long visits. I mean, how cool that we get to have different ways of seeing patients who just need time, expertise, and just to be heard and listened to. And I'm I can't believe so many people logged into this webinar today. We'll post it online. It is such an honor to see all of you, to see your names from international communities. And I do, if this is helpful, let us know on social media. Tell us, tell your friends, because we'll do more. This wasn't hard to do, and we can do more, a subset. We can do one on vestibulodynia, one on lichen sclerosis, one on erectile dysfunction. And so I hope to do more. So give me a thumbs up on your screens, or go to the chat box and say you've enjoyed this. At least lie to me and say that you've enjoyed this. I get a thumbs up from the wonderful Shayna. Thank you for being here. And I got a couple thumbs up. So everyone have a wonderful Thursday, a great weekend. If you have questions, please reach out to any of us, and we hope to see you soon.
And if you have topics for future seminars, please let us know what topics you want to hear about, because we're happy to share that information.
All right. Bye, everybody. Have a great day.